So Albert, we've been taking care of kids with high cholesterol for about 3 decades now, and we've now at the point of releasing this statement through the European Atherosclerosis Society on high cholesterol in children. What do you think gets you most excited about the release of this statement?
The good thing is that we combine the best of both worlds. In the Netherlands, we were lucky to have cascade screening and find a lot of children with a monogenic disorder. But the flaw of this system is that you need an index case. And if this index case isn't there, the relatives won't be found as well. So I think you had another system that we now try to combine. Can you tell us more?
Sure. So in the United States in 1992, we had guidelines which were called opportunistic screening. So if a family had a heart attack within the family or a parent had high cholesterol, you should check their kids. But we know that that really didn't work. So we've recently advocated for universal screening in our 2011 guidelines, and that has resulted in a lot more case identification because kids, because of the genetic high cholesterol, they're much more easily picked up than an adult. In adult, the cholesterol can go up because of diet and all sorts of other reasons, but if you can get a kid, then you can get them early and treat them earlier and also get your index case that way, and that'll help you identify the adults. Since the parents of these children are actually relatively young, by picking up the parents, you might also prevent some heart attacks in the parents. And I think also a key observation from your work is defining the age at which the atherosclerosis really takes off in these young kids.
By doing on routine base, especially in trials, an IMT, we saw already thickening at an early age. At first we thought at the age of 11, but nowadays we know that there is already a significant difference at the age of 7.5 between unaffected siblings and children who are affected. So there is definitely a need to start as early as possible and to try to detect all those who need this therapy.
Yeah, so that at 7 to 10 years of age, you can really see that early deposition of fat in the blood vessels as thickening of the blood vessel. And that's about the age when we can safely give the statin medication to children.
And I believe the good thing is that the parents feel relieved. They feel guilty that they give the wrong genes to the children. But if we can treat them properly, it's not a matter of bringing them into a disease, but we can manage the condition. Is that right?
Yeah, well, I think that's a good way. Yeah, I see 2 challenges. One is, I think the difference between this genetic condition and, let's say, we also take care of kids with heart disease having a hole in the heart, is we can tell a parent, you can have surgery, your child's heart will be normal. So to me, giving a statin to a child with FH is the same, it just takes a little longer to keep the vessels clean. And so I think also if you think about the genetics as a condition, but not a disease, what you're doing by treating this condition is making sure that these children never get a heart attack, which really is a bad disease. And by managing this condition, you can give these children decades of lives and potentially a normal life expectancy.